You're listening to Healing Communities. Your hosts today, Dr. Alicia Spigot and Giovanni Ropolo, are virtual voices designed to reflect the diverse experiences and expertise of Jefferson Applied Health Economics and Outcomes Research community.
Hello, Giovanni. Today's episode features original research conducted by real Jefferson students in our Applied Health Economics and Outcomes Research program addressing critical population health challenges.
So imagine this. You're working on a drug for a deadly disease, but even after it's approved, the question remains, are we using the right dose? Could there be a better approach that saves money without sacrificing effectiveness? It's exactly this kind of problem that Drew Bailey tackled in his Capstone project. I mean, finding a way to optimize cancer drug dosing, it's like unraveling this huge knot. It's complex, but the impact can be profound. And wasn't there a significant knowledge gap around this dosing issue before Drew's work?
There was, and that's what made this project so pivotal. The current FDA-approved dose of Sotorasib, a breakthrough therapy for lung cancer, has been effective but extremely costly. There was very little research on whether a lower dose could achieve the same therapeutic benefits. Drew's work bridges that gap by providing a cost-effectiveness analysis that explores exactly this question.
So, we're talking about addressing one of the biggest concerns in oncology, balancing cost and efficacy. His project used the Partition survival model, right?
The Partition survival model is a sophisticated tool that helps estimate health outcomes and costs across different health states, such as progression-free survival or progressed disease.
Drew applied this model meticulously to show that a reduced 240 milligram dose of Sotorasib could potentially deliver similar outcomes as the standard dose, but at a fraction of the cost. It underscores the kind of impact our program aims for, giving students the tools to not only identify gaps, but also close them with rigorous, actionable research. And speaking of challenges in oncology, when you factor in these KRAS G12C mutations alongside lung cancer's already deadly nature, you're basically fighting a battle on multiple fronts, right?
Exactly. Non-small cell lung cancer, or NSCLC, is the most common type of lung cancer, and KRAS G12C mutations occur in about 13% of those cases. Our tools for addressing it have been limited until Sotorasib came along. It was a groundbreaking approval, the first of its kind specifically targeting this mutation.
Right. And you've got this incredible drug that's a huge win for precision medicine, but, and this is a big but, the costs of treatments like Sotorasib, the standard 960 milligram dose, can be astronomical. So it kind of leaves us with this tough question. How do we ensure broader access without compromising the science? Let's unpack some of the tools Drew used in his project. Alicia, partitioned survival modeling, that method he leaned on, it sounds like something straight out of an advanced analytics textbook. Can you break that down for us?
Absolutely. Partition survival modeling, or PSM, is actually an advanced yet straightforward concept when you break it down. You essentially model a patient's transitions through various health states like progression-free survival, progressed disease, and death over time. These states are informed by clinical data, which in Drew's case came from extrapolated Kaplan-Meier curves.
Right. And he used those survival probabilities to estimate how patients fare, both in terms of clinical outcomes and costs across these health states?
Exactly. For Sotorasib, Drew applied this model to compare the currently approved 960 milligram dose with the potential 240 milligram alternative. The incremental cost-effectiveness ratio, or ICER, for the 240 milligram dose was about $169,107 per quality adjusted life year, or QALY.
So that's how much it costs for 1 year of good quality life at the 240 milligram dose?
Correct. And by comparison, the ICER for the 960 milligram dose was significantly higher, making the 240 milligram dose a much more cost effective option. What's remarkable is how Drew demonstrated this using the Gompertz model for survival curve extrapolation, which fit the data better than alternate models. This rigor and method selection is a hallmark of what students learn in the AHEOR program.
So basically, Drew showed that we can achieve similar survival outcomes at a lower dose with fewer side effects and a much lower cost. It's like hitting a clinical and economic sweet spot.
Exactly, Giovanni. And this type of analysis has far reaching implications, not just for oncology, but for any high cost therapeutic area. By utilizing tools like PSM and economic modeling, Drew's research exemplifies the potential for dose optimization strategies to create value for both patients and the healthcare system.
Alicia, given the compelling outcomes of Drew's project, it seems like there's a strong case for rethinking dose optimization in healthcare. How do efforts like his tie into broader healthcare policy, especially with initiatives like the FDA's Project Optimist gaining traction?
Giovanni, it's transformative. And with that, it's time to wrap up this episode. It's been so great diving into this capstone project and the incredible work being done in Jefferson's AHEOR program. Our goal today has been to share real-world solutions developed by Jefferson students to inspire future leaders in population health. Thank you, Giovanni. And to all our listeners, stay curious, stay engaged, and keep leveraging data to make a difference. Until next time.